Well, this song is dedicated to the children of Africa. We're here to say that no child should be born with HIV in Africa. And if you believe with me, rise on your feet and let's sing together. Yo, 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 yo.
Hello, everybody. Good afternoon, good morning, good evening, wherever you're connecting from. And you're welcome to this session of our Pata Reel, which is the first in the year of 2025. We are indeed delighted to have you as you join us on our session today. And we promise you that the 1 hour we're going to spend together will indeed be one where you have a lot to gain from the session and a lot to write home about. Just as a matter of housekeeping, I just want to make sure that everybody knows what we are here for. We are here for the PATA Reel. Reel is an acronym that stands for reviewing cases, engaging with our peers. I mean, I think it's always exciting to know that somebody in Nigeria is doing what somebody in Tanzania is doing, and it gives us some hope to engage with our peers from different countries and learn what they're doing. It's always so exciting. Of course, we have access to experts. This is one forum that gives you the leeway to engage with top-level persons, to get their views, to also know that they understand what we are going through, and they are always ready to support us on our journey. And of course, and not least, to learn lessons. So I want to implore all of us that as we go through the session for today, it's an opportunity for us to learn lessons from the cases and take it back to our respective countries and facilities. For housekeeping, we don't want to leave anybody behind, and so we have options for interpretation. So you go either to the bottom of your screen or the top of your screen, and you're going to find the globe. That globe, you tap on it and you have a drop-down menu which can help you choose the language you prefer. So this webinar is being translated to French and to Portuguese. So we don't want to leave anyone behind. Make sure you go to the globe and you get connected. We can use the chat box to introduce ourselves. Basically, just tell us who you are and what country you're joining us from, and if possible, the facility. We also have the Q&A box that should help us to ask our questions. As you're asking your questions, we'll have our experts respond to the questions that we are asking on the call. And the hope is that by the end of the session, everybody would have clarified any doubts they had in their minds. So for our session today, our focus is going to be on pediatric HIV and comorbidities. Can we move the slide, please? We understand that it's always quite a complex situation handling cases of comorbidities, especially when we already have a child or an adolescent who is living with HIV. And so we want to try to break it down. We want to try to bring it to life, to make it come alive, for us to experience it, for us to understand that we are not in it alone. There is support for us. There is somebody somewhere who is going through the same kind of thing, and the person has something to say in that regard. For our session today, the focus is going to be quite a bit on our colleagues from Nigeria. Oh, those from Nigeria, I hope that the chat box can be buzzing now with all our Niger friends. You know, just use the chat box, say hello, say hi, invite other colleagues from Nigeria, because indeed we are going to be sharing what is the reality of what has happened in Nigeria. We have 3 cases that will be presented today, and all of them are from Nigeria. So like I said, this is real, and we're keeping it real. So we are going to be going ahead. Hopefully the slides are going to come up again. So just stay with me as I go through the process, and we are going to get around to knowing what our presentation is about. And like I said at the beginning, we promise you that you're in for a great time and you're going to learn a lot. So I said our focus is on Nigeria. And just as a source of some statistics regarding the Global Alliance to End AIDS, which Nigeria is one of the countries that is involved in the Global Alliance, we found that the statistics for the children is a bit disturbing, with just 32% knowing their HIV status. Of course, according to statistics, 100% are on treatment, which I think that's one thing we've done very well as a country. But when we look at suppression rates, we are at 90%, which could explain why we're having some of these children with these comorbidities, or the comorbidities could also explain why the suppression rate is the way it is. So that is why we felt, okay, looking at Nigeria, of course, they are doing something. We can learn from what they are doing, and then we can carry the lessons from Nigeria back to our respective countries to implement. If you are just joining us, you're welcome. Again, this session is going to be all about HIV and comorbidities in children and adolescents living with HIV. These are our speakers. I am Dr. Vanessa Fozao, PATA Country Representative for Cameroon. And joining me on this very interesting panel, we have our exciting experts who are going to help us to facilitate or chair this session. And with me, in terms of experts, we have Dr. Nandita Sugandi, who is a consultant with WHO and is a chair of the Technical Advisory Panel for PATA. She's based in Switzerland, and she is a dedicated pediatrician. So be rest assured that she's going to put in her heart into all the cases we are discussing today. And at the end of the day, the solutions are going to help us to get our children to where we want to get them. Of course, she's held other positions with ICAP, with CHAI, all of which are organizations that are geared towards the well-being of the child. So I can promise you, you're in for a great time. We also have with us Dr. Achari. Dr. Achari is a pediatric infectious disease specialist in the Department of Pediatrics and Child Health at King Edward VII Hospital, affiliated to Nelson Mandela School of Medicine, University of KwaZulu-Natal. He is also actively involved with management of children with HIV, both locally and nationally within South Africa. So we are having the right experts to help us break down the cases rightly. Also joining us as an expert, we have Dr. Filuka, who is the PATA country representative in Tanzania, and she is a specialist with experience in adolescent and youth mental health. So we have our presenters whom I'm going to introduce as we move on into our cases. And so the first case that we are going to look at today is an exciting case that has got a lot of us talking. And the hope is that by the time this case is done, we will see the chat box flooded or the question and answer box flooded with our thoughts and our ideas. This will be presented to us by Dr. Samson Chiwa, who is a senior medical officer at the Federal Medical Center, Jalingo, Nigeria. He's currently a medical doctor at the Department of Internal Medicine and the ART clinic at the Federal Medical Center at Jalingo in Taraba State. So Dr. Samson, you're welcome, and you have the floor to make your presentation. Thank you.
Hello and good morning, everyone. Today,
good morning.
My name is Good morning. So today I'll be presenting the first case from FMC Jalingo, Taraba State, and my name is Dr. Samson Chua, Senior Medical Officer. So the patient was a 14-year-old male diagnosed at 9 months at FMC in 2011. He was the only child born to his mother, who was also living with HIV and mental illness, who was on ARVs at our center. His father was not present in his life. The child was fully disclosed to, and his father was not present throughout his life. And his most, beg your pardon, he was fully disclosed to by his mother with assistance from healthcare worker. His father's status was, however, unknown. His mother passed away in December 2024 at home. Cause of death was unknown. He was a JSS3 student, a class appropriate for his age, and said to be doing well. And he was a member of the Youth Friendly Club at the facility at Operation 000 Club. Child lived with his mother and grandfather. Although his mother was unemployed, she and her relatives were his only source of support. Patient was noticed to have had poor drug adherence from 2022 to 2023. This was attributed to his mother refusing to give him his ARVs on account of him being healed after being taken to a spiritual healing house, despite him being regular with pediatric clinics and drug follow-ups. Next slide. So the child presented on the 14th of August 2023 at the pediatric clinic with herpes zoster rash. Acyclovir cream tablets with prednisolone were prescribed, but patient could not afford due to financial constraints. A month later, he presented to the emergency pediatric unit with complaints of fever, headache, vomiting, irrational talk, and behavior of 3 days duration, with loss of consciousness and convulsion of 1 hour duration. On examination, he was chronically ill-looking, unconscious, convulsing, pale, not jaundiced, dehydrated, had ulcers on his back, which did not cross the dermatome. His weight was 30 kg. The CVS findings was a BP of 60-50 millimeters mercury, pulse rate of 88 beats per minute, which was weak and treading. Respiratory rate was 28 cycles per minute. His CNS findings was a Glasgow Coma score of 4 over 15. An initial assessment of query cerebral malaria to rule out meningoencephalitis in a patient with retroviral disease was made. He was admitted to the emergency pediatric unit and was managed appropriately. He failed to regain consciousness after 4 days of admission and developed anemia. Investigations was a low PCV of 26%, low sodium, and elevated urea and creatinine. His TB lamp was negative and crack antigen was negative. CSF analysis was not available, and the CD4 count was less than 200 cells per microliter. A definitive assessment of meningoencephalitis with HIV-associated nephropathy, HIVAN, or end-stage renal disease, when an RVD stage 4 was made. He regained consciousness after 1 session of transfusion and dialysis. He was continued on antibiotics, anticonvulsants, and nutritional rehabilitation. His ARVs was changed from abacavir, lamivudine, and the dolutegravir from TLD, and had blood transfusions about 5 times, renal dialysis 6 sessions, and then he was discharged after 5 weeks. He was readmitted 4 days later with convulsions. He was 4 days later still with convulsions. His BP then was 120, 110. Pulse rate was 114 beats per minute. He had ascites, pulmonary edema, and he had an elevated creatinine of 1,435.7 millimole per liter and a urea of 44.1 millimoles. Potassium was 4.6. An assessment then was made of Hyvan with encephalitis, in bracket, uremic or hypertensive. He underwent further dialysis, had 4 sessions of dialysis in total at this present admission, and was managed accordingly. He was given a lisinopril and nodipine to manage his hypertension, but was discharged after 2 weeks of admission. He returned 3 weeks later with similar complaints and was readmitted for further management. This pattern continued with repeated hospital stays. Total blood transfusion was about 10, dialysis was 16, until his death on the 8th of April 2024. His patient relatives were advised for renal transplant therapy. By 2011, when he was initiated on ARV with lamivudine, ridovudine, and nevirapine with Septrin tablets. Then between 2011 to 2019, the CD4 count ranged from 800 cells to about 551 cells. By 2021, he was then changed to lamivudine, abacavir, and dolutegravir ARV combination. TLD was then optimized to TLD when he attained a weight of 30 kg by 2021. 2022, we saw a rise in his viral load to reaching about 965 copies. He was then referred for enhanced adherence counseling, after which he then had a suppression rate of less than 30 copies per mil after 3 months, and then he was then joined for OTZ to the OTZ club. By 2023, however, we saw a rise of the CD4 count to about 142,000 copies per mil due to poor adherence. This led to him being diagnosed of HIV-associated nephropathy, warranting him being changed from the TLD back to the lamivudine, abacavir, and TTG regimens. By 2024, while on admission, samples was collected, for viral load. However, patient died before his viral load results were retrieved. So key challenges we faced with this patient was there was a lack of parental support concerning drug adherence. The second was psychosociological factors leading to virological failure and development of Hyvan. Key lessons learned: routine renal function tests for both old and new recipients of care should be mandatory, especially on those on tenofovir-containing regimens. A community-based organization can play an important role in assisting patients in socioeconomic challenges. So questions for our expert panelists today is renal transplant a definitive treatment for Hyvan? And what are the early markers that could be seen, or what should we be actively looking out for in pediatric population, which could potentially be pointers to renal disease on a background retroviral disease? Then lastly, how often should renal function tests be carried out for pediatric clients on TLD? Thank you very much.
Wow, thank you. Thank you very much, Dr. Sampson. Just before I give the floor to our experts to respond, if you are just joining us, you're welcome. And today we are discussing HIV and comorbidities in children and adolescent population. So I'll give the floor to our experts to respond to the questions the team has asked. Thank you.
Thanks so much, Dr. Vanessa and Dr. Sampson. Thank you for presenting a really fantastic case. And I want to address your questions, but I also just want to make a quick comment that this patient was in care for a very long time. And, starting care in 2011 and doing well on AZT3TC, nevirapine, and cotrimoxazole. He made it to 14. And, from your first slide, it really looked like he was well cared for. He had been disclosed to, he was in school at an appropriate level, he was engaged in the peer group in OTZ. So, you know, from initially, I can imagine this is a very disappointing outcome, and it's very difficult after we've taken care of children for so long and watched them grow up to see this type of sudden mortality. In terms of HIV-associated nephropathy, so when we say renal transplant, I think really the thing to remember is this nephropathy is caused by the virus itself, right? So there's over time the pathophysiology, I think, is pretty complicated from what I recall. But if we think about what the definitive treatment or cure would really be ART, right? And we would want to have identified this earlier. So I appreciate sort of the thinking through, because I think these are the types of cases that we learn from. And oftentimes we also worry about nephrotoxicity with the use of tenofovir, and this child had switched at an appropriate age and weight to a tenofovir-based regimen, which is highly effective and looked like from the first initial few viral loads that he was doing well on that treatment. And when we see kidney or renal toxicity or nephrotoxicity in tenofovir, it's usually a slower process that comes up within, a year. It starts presenting in the first couple of years. But what we usually recommend is, number one, knowing that tenofovir toxicity is the prevalence, the rate of toxicity is very, very low, and most children and adolescents and adults do very well on tenofovir for for many years. There is a recommendation to monitor creatinine, but again, recognizing that not everybody will have a rise in their creatinine. Some people will have maybe an initial rise due to some of the ways that the body processes protein and displaces it. So there's initially a small bump in creatinine that normalizes, but we usually don't see large increases. And that's not very common. But what we would recommend is in the first few months, maybe after 2-3 months of tenofovir or after a year, checking a creatinine, and then monitoring to make sure that it's normal. But once if it's normal, then there's not always a need to continue monitoring unless there becomes concern for renal insufficiency. And so there are other, in addition to looking at creatinine, which is a sensitive indicator of kidney function, and we can look at, but we can look at other markers of renal dysfunction, and that includes things like weight loss, anorexia, and higher blood pressure as well. So I think these are things that he presented with, and really when he presented, he came in shock. Right, so there's also maybe a risk that there was some organ damage during that period of shock, and so his presentation was really striking as well. Now, whether his encephalopathy was caused by hyperuremia, whether it was a we had also noted that he had varicella zoster by those lesions, which also tells us, even without a CD4 count, that he was immunosuppressed. But these varicella zoster can also cause an encephalopathy following an episode of zoster. Now, that said, I think in this case, it could be either, because we know that he had not been on treatment for a couple of years. And I think this is my last point about sort of really making sure that we know what's happening with our patients. Again, this was a otherwise healthy 14-year-old boy who suddenly deteriorated. And I think for me, there are a few lessons, especially at this point in time when we're very worried about ART programs, especially for young people, where we have to remember that really when they're doing, even if they're doing well on their medications, that psychosocial support is important, peer support is important. There's a lot that tells us if they're doing well, if they're in school, if they're thriving. But it's also a reminder that we have to know what's happening, what they're hearing. And I'm wondering if, in some of these discussions in the OTED-TZ groups, if we're preparing our young people for some of the myths and misconceptions that are in the community that they may hear. So that's another point to make. But really, this was a tragic case. And one that we hope we don't see often. It was really complicated, and I really applaud the team for taking such careful care of this child.
Thank you very much, Dr. Nandita. Dr. Achari, do you have a few comments to add before we move on to the next case? Thank you.
Yeah, thank you very much. Again, I think I just want to reiterate, what Nandita said. It's a really unfortunate case where, that this child looked like that was going on a really positive trajectory. And it's really sad that we've, had this negative outcome. And really, I think it does speak to the need for us to really engage with the community and, to address many of these misconceptions and untruths that are out there that may actually get worse in the next, there's coming months as many of these services that support of these our programs, come down. So I think we do need to, be aware of them and try to meet to address them head on. The 2 points I wanted to make was really around, I think this early treatment and detection of HIVAN. I think the one thing is, we have a fair amount of children with HIVAN. They don't all need treatment, renal transplantation. The problem with HIVAN is that the pathophysiology is a rapidly progressive glomerulosclerosis, so they end up with quite severe end-stage renal impairment. And as Nandita said, it's driven by the virus. So ultimately, getting that virus down and allowing that kidney to heal is the most important thing. So early detection of virological failure, and especially in this patient with advanced HIV disease, is important in improving that outcome for him. And we have several children that once we've controlled the HIV virus, we often in consultation with our renal physicians, we'll put them on some medication to decrease the proteinuria, which is often a signature that happens with these participants or these patients. In addition, with short courses of steroids. And we can get control of the infection and prevent them from going on to end-stage renal failure, which unfortunately this child had. Again, to support Nandita, I think in tenofovir, I don't think was the major driver of this. Unfortunately, HIVAN is a function of advanced HIV disease, and that's the real driver of this of the outcome in this patient. There is a need to routinely monitor your creatinine and do we have to modify that. You look at the creatinine clearance, which has to be and there's formulas, and if you go into online, there's Bennett Collard formula that you can use, and that adjusts it for the for adolescents and helps you interpret the degree of renal impairment. The other early marker is also proteinuria. So doing a protein dipstick in patients and if they have persistent proteinuria, that's usually a very early sign of impending HIVAN, and then progressing on to that. And then the last point I wanted to make is really around this transition from TLD back to ALD in this patient. And in this participant, I think we're quite certain that the viral failure was from non-adherence, and especially with non-adherence to a fixed dose combination to TLD, what we often find, and especially in first line, and this kid, was suppressed up to that point and would be considered to be essentially a first line dolutegravir user, that we don't see very much resistance. So I'll be quite happy from a biological failure perspective to transition from a TLD to a ALD regimen in this child. I'll stop there. Thanks.
Thank you very much, Dr. Achari. And if you're just joining us, you're welcome. Again, we are discussing comorbidities in children and adolescents living with HIV. And we've now just rounded up with the first case, which had to do with HIVAN. And our experts, our presenter presented the case very beautifully for us, and the experts have given us insights. The expectation is that we as participants in this session, by the time we're going back to our countries, to our facilities, we will now know what to do in terms of early detection of HIVAN, because as we've heard, we have to detect early and then we have to intervene. So I'm sure with that guidance, we know what to do. We are encouraged to use the Q&A box to ask our questions, and the responses will be provided, while we keep using the chat box to introduce ourselves as we log on to the call. Right now, we're going to be having our second case. Again, our focus is on Nigeria. Nigerian colleagues, all the way, it's you today. You're winning today. I love you dearly. You're my neighbors. So the second case is going to be presented for us by Matron Flora Obele. She's the ART coordinator at the Obio Cottage Hospital, Port Harcourt, Nigeria. She's a registered nurse and midwife working as an assistant chief nursing officer at the Obio Cottage Hospital. She's the ART coordinator, like we said, and the PMCT focal person, as well as she is the GBV focal person at the facility. She has a vast experience, and so right now I'm going to welcome her to guide us through the second presentation. Thank you, and Matron Flora, you have the floor.
Thank you very much, Dr. Vanessa, and welcome everyone. So today we are presenting a 20-year-old male patient diagnosed with HIV on the 1st of July, 2020. While alive, he lived in a 2-bedroom apartment with 4 siblings, and his mother passed away from asthma, and his father also is deceased from unknown cause. So at the time of presentation, the patient was a second-year university undergraduate studying philosophy. He was gay and was struggling with his sexuality and acceptability in the community. So an uncle serves as their primary caregiver and was not in support of his sexual orientation. Hence, they had a strained relationship. Upon presentation on July 1st, 2020, the patient reported a productive cough with mucous sputum, hemoptysis lasting 3 weeks. There was significant weight loss. He used to weigh 65 kg and difficulty in breathing. There was no history of contact with an adult that had or has a chronic cough. On physical examination, the respiratory system, vesicular breath sounds were noted with a respiratory rate of 40 breaths per minute. There were no other significant findings in other systems. His vitals were BP 110, 75 millimeter mercury, pulse 126 beats last day, and his weight was 47 kg and height 169 centimeter. His blood pressures throughout his stay with us were within normal range for his age. So investigations that were written out for him was to do chest X-ray. We found infiltrates in the upper lobe with cavitations. That was consistent with probably pulmonary tuberculosis on a background of HIV. The serum electrolytes, urea creatinine were all normal, and a diagnosis of newly diagnosed patient with viral disease with tuberculosis was made. So the initial treatment plan was to refer patient to a directly observed therapy center, which was done. And patient was instructed to return after 2 weeks to commence the antiretroviral therapy. Patient came back on 17th, 2020, and ART was initiated. The patient was staged as WHO stage 3. So, during his stay with us, we had these viral load histories, and as can be seen here, because he was really non-adherent, when he managed to come after being on the ART for more than 6 months, his viral load was 1 million plus. And during counseling, non-adherence issues were noted. And he was unsuppressed from 2021 to November 2022. All extended adherence counseling was commenced, patient was visited, patient was encouraged, but then he only became suppressed in April 2023 until May 2024, where his viral load was 20 copies per mil. But then in September 2024, after he had been absent from clinic visits, his viral load became 1,102,912. Patients claimed he missed the appointment because he was on admission in another facility. Next, please. Over time, the patient was chronically non-adherent to both clinic visits and medication regimens. Despite several outreach efforts, he was found to be in progressively worse medical condition. But on the 3rd of March 2020, he complained of a well-circumscribed rash on the posterior right side of the upper back, under the right armpit, and a white plaque was seen at the posterior end of the upper jaw. A diagnosis of candidiasis was made, and antifungals were given. The issue around non-adherence continued despite the continuous counseling. Patient returned to the facility in December 2024 in an unconscious state. He was thus referred to Rivers State University Teaching Hospital for further management. Next, please. On final presentation, while at the teaching hospital, the patient was found to have a left-sided hemiplegia, still unconscious, that led to a probable diagnosis of cerebral toxoplasmosis to rule out a space-occupying lesion on a background of HIV. Patient was reclassified as WHO stage 4. Imaging wasn't done because of financial constraints. The patient passed away 2 days later in January 2025 at the referral center as reported by next of kin. So during the care, next slide, please. During the care of this, next slide, please. During the care of these patients, we encountered many challenges and as well as learned many lessons. Number one challenge was a non-adherence to treatment, persistent non-adherence to ART and clinic visits despite multiple outreach attempts, resistance to taking medication as reported by the caregiver. We have some psychosocial barriers, loss of both parents and reliance on an uncle as a caregiver, likely contributing to emotional and psychosocial instability. So, possible lack of strong family or community support for adherence to treatment. The socioeconomic status of the patient led to financial, lack of financial support for medical bills. The lessons we learned was adherence challenges, persistent non-adherence to ART and TB treatment can lead to rapid disease progression and poor outcomes. Addressing psychosocial and behavioral barriers is critical in such cases. Importance of early intervention, timely diagnosis, and consistent follow-up are essential to prevent complications, associated with HIV and TB infection. Community and family support is like engaging caregivers and leveraging on community-based intervention can improve adherence and provide essential support for patients with complex health needs. So comprehensive care approach like involving a multidisciplinary team, clinicians, counselors, and social workers is crucial for managing patients with significant social and medical challenges. So our questions, next slide, please. Our question to the experts. What baseline and routine assessment should be conducted for adolescents living with HIV to detect early signs of complications and prompt referral? What other factors associated with HIV could have contributed to partial hemiplegia in this client? Should imaging studies such as brain MRIs or CT scans be more frequently employed to assess for subclinical cerebrovascular risks in high-risk patients? And lastly, what preventive measures can be taken to reduce the risk of severe complications, such as neurological manifestations in adolescents with advanced HIV? So, thank you very much for having me. That is our case.
Thank you very much, Matron Flora. I see Dr. Achari is on. Thank you. If you're just joining us again, we are speaking to comorbidities in adolescents and children living with HIV. Feel free to introduce yourself in the chat box. If you have questions, please place them in the Q&A box, not in the chat box, so that our experts can respond. Dr. Achari, you have the floor. Thank you.
Yeah, great. Thanks, Vanessa. And Flora, thanks for the case. I mean, again, I think really a sad outcome for both this patient, but also the family, and also for the team looking after this this patient. And again, I think the main thing with all of these cases is, even with a negative outcome, we're hoping that we can learn from the experience and hopefully do better and help other patients from these experiences. So I think I just want to start from really the beginning, and I think reflecting back on both our experiences in South Africa, but also I think it's going to be the same across Africa. What we're going to see is there's going to be quite a marked reduction in terms of social supports for key populations, because that seems to be one of the main areas that have been that has been curtailed as part of the reduction in foreign funding. And certainly this patient falls within that key population as a gay male. And so I think one thing is really we do need to find ways in which, both from the community perspective and also other structures that we have within our health facility, but also within the community, that we do need to put things into place in order to support key populations, because as you can see here, they have very few other supports to fall back on, and they become very vulnerable to having the worst outcome and the least amount of assistance as they navigate this. And certainly I think in this he was 20, but he's very likely at the time of his presentation, it sounded like he already had quite advanced HIV disease and probably had was infected quite early. And the earlier identification of your risk profile, and we've seen in other homosexual populations that the use of pre-exposure prophylaxis at a community level has made a huge difference in terms of decreasing HIV acquisition in these key populations. So I think, and again, pre-exposure prophylaxis is going to decrease in the coming years. So I think we, as health care providers, we do need to advocate for the continuation of supporting key populations and continuation of provision of PrEP to prevent new HIV infections. The second point I wanted to make was really around the initial diagnosis of TB. I think it was very likely that he had TB, and although you didn't make a definitive diagnosis from that, What I didn't see in the presentation is, again, in a patient with very low CD4 counts, you can do a urinary lamb. And again, the gene expert from sputum may also have been able to pick up the infection, but thankfully you've started the patient on TB treatment. The other point I wanted to make was in terms of the management of patients on a rifampicin-based TB regimen in conjunction with TLD. I didn't see it in the presentation, but they should actually go on to have an additional dose of dolutegravir as well. So in addition to taking the TLD in the evening, or in the morning, they should take a dose of dolutegravir, 50 milligrams, 12 hours apart from that, and that prevents that viral load from the impact of the rifampicin on the dolutegravir levels, and decreasing, having subtherapeutic levels of dolutegravir, and obviously impacting the ability to maintain suppression. And then, again, reflecting back on, the social support, I think it's extremely difficult where there are very few, other support structures within the patient's family and other support areas. But the one thing that also struck me quite clearly was, there's obviously some mental health issues that needed to be addressed. So evaluating, mental health, depression, anxiety in this patient may have, to some extent, mitigated some of the defaulting and the inability to engage in care. And then lastly, coming to the final bits of the presentation, which again, in a patient presenting with advanced HIV disease with a hemiplegia, the differential is quite wide. Infection always comes in quite highly. Both apart from toxoplasmosis, Cryptococcus meningitis can present with a vasculitis and a hemiplegia. TB meningitis with a vasculitis and bacterial infections can result in hemiplegia. Also, in advanced HIV disease, you have an increased incidence of malignancies, and the top CNS malignancy is a CNS lymphoma. So that's again another possibility that this this participant had. And then, in addition to that, with HIV and uncontrolled HIV, you get an increase in terms of a vasculopathy. So you increase in the predisposition to cerebral vascular events, so they get thrombosis and increased thrombogenic events in the brain, and so infarcts related to ischemic cerebral event. So again, I think you do need to, unfortunately, do several tests, including imaging, in order to make a proper diagnosis. If what you could have done was a serum CRAG may have been able to detect whether there's cryptococcal meningitis, and if a LP was not available. If it was safe to do an LP, a lumbar puncture looking for cryptococcus and TB and other infective or bacteria would have been able to assist you in terms of deciding where to go with the treatment. And then obviously, tailoring your management according to, where you, or what you find out in that patient. And again, I think, unfortunately, the best prevention is getting that viral load down, making sure that CD4 count remains as high as possible. And if the CRAG was positive, he was asymptomatic, we would have considered putting him onto prophylactic fluconazole, which potentially, if he had cryptococcal meningitis, would have prevented a severe catastrophic event. So yeah, again, I think unfortunate, but again, I think a lot of learning points that we hopefully can take forward. Thanks.
Yeah. Thank you.
Thank you very much, Dr. Achari. Again, we find that these cases are quite complex. And so we are here not trying to discredit anything, but just to try and break it down, to let you know that you're not in it alone. others are experiencing it. And to back that up, we have a comment from Rose Mukoto, who says that, thanks so much for the insightful and unfortunate cases we saw. Typically, these challenges are real. Again, we are coming back to our real in most countries. I had a similar case in South Africa, and it's quite clear that a holistic and intersectoral approach is critical to improve our outcomes. Yeah, she has mentioned holistic and intersectoral. Dr. Achari has given us a lot of pointers that are clinical, but as you heard from this case, this guy had multiple psychosocial factors, which could be the reason why he did not take his medication or was not adherent to the medications evident in the high viral loads we saw. So I will just hand the floor to Dr. Filuka, which will give us a few inputs around the psychosocial care of this young adults and what we could have done or we can do at our respective points to help such an adolescent. Thank you. And Dr. Filuka, you have the floor.
Yeah, thank you very much. Yes, I would really second to Dr. Achari about the psychosocial part, and we really need to work with the community and also the family. But looking at this 20-year-old male, and I know he was diagnosed at age of 20, and I think there's a dilemma there where to put him. So at age of 20 is belong to the young people, age of 10 to 24, and then perhaps they may be taken to adult care. And in adult care, you find that it's a business as usual and no much of the peer support services and all that in the adult care. So this is the kind of a person that when you get this patient, you kind of think at age of 20, what other assessment I should do and where should I put him, either in adolescent clinic where he get more support, get to see his peers and understand, when engaged into the peer support group sessions, they might be very hopeful to really become more motivated to take a medication. So that's part. And with regard to the vulnerability that this patient has, first of all, is orphan. It's the young person as well as he's gay. So this is very risky population, which they tend to be more vulnerable in our community, and they may end up with non-adherence and with high viral load and engage into the very high risky behavior. So with that, for the first time that I know we test and treat. So with that, we need to prolong that counseling. With this kind of patient, we prolong more and engaging more. I understand with young people, they tend to agree at the beginning and accepting it with the HIV, but internalizing it might be difficult. So you may want to have this young person to be in a prolonged sessions of counseling. Even after he started treatment, you continue counseling so that we understand that he accepts the treatment and he accepts his HIV status. And looking into that, also we need to do the mental health assessment or refer to assess for the mental health so that he can get treatment, whether he has a depression or anxiety, and refer. So I understand in primary care, sometimes you may not have a clinical psychology or you may have a clinical psychology. So where to refer, that is another thing that you need to think of. And also looking at the networks, the gay network, LGBTQ network, so that he can engage there, so that he can also having a support. This is the kind of a patient who didn't have any support from the family or even in the community. So you need to look at and see what other community entities or community stakeholders that can support them with this, and also thinking about the PrEP and others, so to reduce the transmission. So with that, I know I can see Vanessa is looking at me. So I know I have a little time, but thinking around the test and treat, just you can prolong this adherence and do the readiness assessment to this young person to see whether he can be able to self-manage, or he needs to get a treatment supporter or a peer supporters that can support him. Yeah, so that's me, and perhaps we can discuss further with this patient or later. Thank you.
Thank you very much, Dr. Filuka. Again, if you're joining us, we are discussing comorbidities in children and adolescents living with HIV. And we've now just concluded with the second case, which unfortunately also led to a negative outcome. Yes, I know that it can be depressing, to manage children, and at the end you find that the children have died. It's just as a beacon of hope to all of us. Dr. Nandita, you have the floor to make your contribution before we move to the next case, which will be our last. And just to plead with us that we may go a little bit over time, please be patient with us. These are quite complex cases, and we have a lot to learn from the cases. Again, if you have questions or contributions, use the Q&A box, because if you put in the chat, we may miss it out. The chat is for you to introduce yourselves. Thank you, Dr. Nandita, over.
Thank you, Dr. Vanessa. And I have to say to Dr. Mo and Dr. Filuka, I think they covered the case very well. And also to point out, I think from both these cases, these are both young people who could have done very well in their lives. And it's really, it's a tragedy that both their lives were cut so short. What I wanted to say about this last case is just the multiple vulnerabilities. And I know Dr. Filuka spoke to this, but I think, again, this really needs to be something of a cautionary tale for many of us. Again, it's important, the young people in our lives have a lot of complicated factors. And we know this is a time period where they're thinking about sexuality, where they're exploring their identities. And it's important that we, again, share messages with them that provide a safe space, that they feel that they know where to go for correct information. And I think that's one of the roles of healthcare workers, is really to be attuned to some of those vulnerabilities that have, put both these young men in very tragic circumstances.
Okay. Thank you very much, Dr. Nandita, for that add-on. And I'm sure our service providers heard you clearly. And it comes again as a beacon of hope for them to know they are not alone, and to know that there is hope and there's light at the end of the tunnel. We are going to move very rapidly to our third case. And this third case will be done for us by Dr. Kibu Mark, who is the National Clinical Mentor at NASCAP, Taraba State Specialist Hospital, Jalingo, Nigeria. He is, of course, a dedicated public health enthusiast with a passion for improving healthcare outcomes for our children. He provides expert clinical trainings to clinicians on HIV services according to the national treatment guidelines. And so it means that we are up for a great presentation. Again, I want to plead with us that we should be patient. I know we've gone over time, but we promise that it's worth your while. And we know when you're leaving here, you'll be leaving here smiling. So thank you, Dr. Mark, you have the floor.
All right, so thank you very much, Dr. Vanessa, and good afternoon to all the listeners. And so I'll be taking the next case. Next slide, please. So the patient is a 12-year-old male diagnosed with HIV when he was 10 years old at this facility. That's the Taraba State Specialist Hospital on 10th of November 2023. He is the second child of 5 children, living with his father, who is separated from his mother. His other siblings are HIV negative. His status has fully been disclosed to him at his current age of 12. The family's diet is majorly starch-based food with occasional protein supplements, and they barely get 2 complete meals a day. He has completed primary education and has yet to enroll in a secondary school because of the financial constraints of the caregiver, his father, who is fully responsible for his care since the separation of his parents. He has since been assigned to a facility case manager who ensures his ART care and follow-up. He presented at the facility through the emergency pediatric unit as at when he was 10 years old, with symptoms of generalized body weakness and loss of appetite, all of 2 weeks duration, and irrational thought and behaviors of 3 days duration. All of his symptoms were said to be progressive and worsening since the onset. There was no history of vomiting, frequent passage of watery stool and cough, no history of fever and loss of consciousness. So on examination, he was found to be chronically ill-looking with abnormal gaze. He was very pale, dehydrated, not cyanosed. However, there was pitting pedal edema. His weight as at then was 16.5 kilograms. His height was 1.2 meters. His body mass index was 11.4 kilogram per meter square, which was out of range. For his cardiovascular system, the pulse rate is elevated at 130 beats per minute. Other findings are within normal range. And for the respiratory system, he was found to be dyspneic with a respiratory rate of 16 cycles per minute, and there were widespread crepitations on expulsion. For the GIT, no abnormalities were found in that system. For the central nervous system, however, he was delirious with occasional irrational talks. He was then promptly admitted and managed initially as a case of advanced HIV disease, stage 4, with wasting syndrome plus an encephalitis. His CD4 count at initiation was less than 200 cells per millimeter cube. TB-LAM was negative. Other investigations requested included an urgent PCV grouping and cross-match of 2 units of blood. A chest X-ray was also requested due to the findings from the respiratory examination. Full blood count, the sputum gene expert was also requested, electrolyte urea and creatinine, and urinalysis. He was then resuscitated with pediatric saline, broad spectrum antibiotics, including ceftriaxone and fluconazole, and was commenced on abacavir, lamivudine, and DTG, pediatric INH, and Cotrim. So he's on day 2 on admission, he was reviewed with the investigation results. The gene expert came out as negative, CRAG was negative. Electrolyte urea and creatinine revealed hyponatremia, while PCV as at then was 10%. Hence, his diagnosis was also changed to severe acute malnutrition due to the examination findings, and also the very poor nutritional history, which include pedal edema, and then a body mass index that was less than -2 standard deviation. All of this in background advanced HIV disease. And a plan was instituted which include a blood transfusion and for the broad spectrum antibiotics to be continued. And a dietitian and a psychiatrist were also called to review, and the dietitian prescribed high protein diet, including 45 pap and 2 eggs per day, and other management continued. However, on day 4 on admission, after review and then some of his abnormalities were getting better, such as the Paxil volume, which increased 23%, and his weight to 18 kilograms, the caregiver requested for a discharge against medical advice, all due to financial constraint. Next slide. And a history of his viral load management, right from initiation to his current status. At 3 months post-initiation, his viral load was unsuppressed with 113,000 copies per meal. And all of these were due to poor nutrition, some of the side effects from the ARVs, and also some level of negligence from the caregiver. He was immediately commenced on enhanced adherence counseling, and all the adherence issues were addressed. This was very helpful, as his viral load dropped to less than 20 copies per meal at about 6 months after the first EAC session. He was then optimized on his ART to the tenofovir lamivudine and dolutegravir regimen, and having attained a weight of 32 kg without any complaint as at the last time he visited the facility. Some of the challenges were encountered during the management of this client included the coexisting severe acute malnutrition and irrational behavior that initially affected his ARV intake and adherence, and also limited diagnostic capacity, including CT scan and MRI, which were not available to be able to rule out some of the diagnoses that were initially entertained. So the lesson learned in the management is basically that a social work or welfare department can actually be made available in the facility to support and improve treatment outcomes. So for the questions we have for the experts, we projected soon. Thank you, and that is over from me.
Doc, please go ahead and ask your questions. Thank you.
Okay. All right. So for my question, would a lumbar puncture be necessary for this child to rule out an encephalitis when he initially presented to the facility? And then the last question is, what is refeeding syndrome, and how can it be managed in the context of severe acute malnutrition and in this child? Thank you, and over from me.
Thank you very much. Just before I hand over to the panelists, if you're just joining us again, we are discussing comorbidities in children and adolescents living with HIV. And we've had a lot of beautiful cases presented to us with unfortunate outcomes. I think there's light at the end of the tunnel, because with this last case, at least our adolescent is alive. And so I'm just going to hand over the floor to the experts to make their contributions and respond to the cases. Again, if you have questions, you can put in the Q&A box, and you can use the chat to introduce yourself. Thank you.
Thanks so much for that, for this case. And I think, as Dr. Vanessa just mentioned, there's hopefully some light at the end of the tunnel when we look at these cases. But I think this is, again, really one of those cases where we look at it and think, what could we have done to prevent some of this? And just to the answer to this question about lumbar puncture, if it's necessary or not. And I think that's a challenging question, because sometimes we don't have the equipment, or we don't have the permission to do a lumbar puncture, or somebody is not stable enough. A lumbar puncture helps in this circumstance to figure out if if there's a potential infection that needs to be treated. We can often make out some clues as to the diagnosis based on the CSF. But if we don't have one, then there's still other things that we can do, right? So I think we also want to make sure that we know how to practice, even when all the tools and other diagnostics we usually depend on are not available. And so I think this is, again, one of those questions. And I think it comes back to how the child presented. And when he presented with severe acute malnutrition. And this comes back to our the second question here, which when we think about what severe acute malnutrition is, it's a complete derangement of all metabolic functions in the body. And so there is hyponatremia, hyperphosphatemia, and a lot of these imbalances, and that could even cause cognitive issues as well. And I think there are a number of reasons that this could have happened. Now, are there other things that we should be thinking about? Intoxication, mental health, those are other things, but again, it would require really what's most helpful is to know your patients. And I know we're over time, but I'll share it very briefly. I once had a patient who was incredibly immunosuppressed, and I had taken the care of this patient over from another doctor who had left. And when I first met her, she was so bright and bubbly and cheerful. And I thought, oh, there's no problem with this girl. But it was her friends who came to me and said, look, she's not acting like herself. This is not her. And it turned out that she actually had some space occupying lesions. And at the end, it was that kind of close understanding of who a child is, right? And noticing when there's a difference. Now, refeeding syndrome, again, just going back to severe malnutrition, again, is a derangement of most of the systems of the body. And this includes fluid balances, this includes the gut as well. And so how it's managed is by slowly reintroducing food. So not introducing a full diet, but going slowly over time. And it sounds like in the course of this patient's care that he started to make some improvements. We can see that by his weight gain. I think the edema had resolved as well. So in some sense, I think we also need to look at a patient's course over time and how they improve or what changes their behavior also can give us some ideas about what's happening. And I'll stop there for now.
Thank you very much, Dr. Nandita. Yes, Dr. Filuka, I see you've put on your camera, so you have the floor.
Yeah, thanks. Thank you so much, Dr. Vanessa. Yes, for this case, with the age of 12, already know his HIV status and has siblings who are HIV negative, that and the parent and the father who is also struggling financially, put him in the situation where he may be having three issues here around stigma, safety, as well as financial. Those financial difficulties the father may end up to neglect the child while fighting for the to resolve his financial difficulties and bringing the food on the table. So looking at these three things, at the age of 12, they may wonder, why am I the only person who's taking medication at home? And that could also bring in the mental health issues. And these are kind of patients who we need a thorough mental health assessment, as well as the continuous support with the peer support, as well as the health providers, and advocating for either linking to the clinical psychologist or looking at the any other stakeholders within the catchment areas, whether they provide any, for example, food or other social services that they can provide to this young person. Other thing is the safety. So I understand perhaps we need to understand the parental involvement with the children around this adolescent period, and we need to also assess them, providing them knowledge, and also looking at maybe perhaps we can even refer to the social worker to do the social assessment of the family, looking at whether there's a food available or any other thing that they need to be able to assist or refer to the social services that they can get services or support. Addressing this social support network of this young person, and as well as looking at if there's any kind or form of abuse or anything at home. So with the financial difficulty, it's the same. When you involve the parents and engage them and assess them, they may be able to also be able to talk to the health provider and tell them what they're struggling with, and perhaps the health provider can also link them to where they can get support, or provide them with that support, that especially with the knowledge, understanding that they need, and the importance of the young person to take medication and to have food and all that around. So it is unfortunate with a 12-year-old who was progressing well and ended up with severe acute malnutrition, and all other things that around him. And it may be very scary towards him. And for now, because this is the patient who is still alive, so we need to really set plans. Once he's much stable, what can we do in terms of her safety, in terms of his financial stability at home, in terms of assessing the stigma, assessing the mental illness around with the child, even with the family, especially the father, and looking at what other support this child can have with within the community. Yeah, thanks.
Thank you very much, Dr. Filuka, for those insights. And I'm sure that our presenters have had a feel. And I'm hoping that you, as participants in this session, have equally had some eye-opening presentations. I mean, today we've been talking about comorbidities in children and adolescents living with HIV, and we've touched on different topics. We've looked at their kidneys, which was our first case, focused and talking a bit around HIVAN and how we can identify it early and how we can intervene to make sure that we are keeping our children and adolescents alive. We also looked at the lungs in terms of the second case, where we had a case of TB initially, and we saw a progression to with the child having other neurological manifestations, which just shows us that children can progress if all is not well with their management, and if there are certain factors that that can worsen their progress, and the outcome can really be bad. And yes, we are not oblivious to our realities, where there's often absence of resources, financial resources, or even a platform to make adequate diagnosis and manage them adequately. And finally, we looked at their feeding. You know, sometimes we think eating is easy, but until you find children with malnutrition, then you see that, oh, there are a lot of factors that come into somebody being able to eat. So I think we've had a very wonderful session. We have exhaustively had our real session where we have reviewed the cases. We have engaged with our peers. We have had access to our experts. Thank you very much for being a part of the panel. And of course, I'm sure there are multiple lessons we've learned. I'm sure a lot of us have had that aha moment, like, oh, this is what I should have done, or this is what I should do with this case. That is the expectation. Hoping that we've understood that managing comorbidities is always very complex. Let us watch out for all these early markers that we can pick up with our children, and that can only be done if we know our clients, if we engage them on all fronts, if we provide a holistic management, and if we endeavor to transfer or refer our patients as early as possible, so that we avoid the adverse outcomes that that can befall our children. I want to thank our presenters for taking out the time to prepare the cases, and hopefully we'll follow up with all of the insights we've gotten. I want to thank our experts for making themselves available and engaging with our population to really bring them insights as to what they can do to make it real and to live through these real circumstances that we experience on the field. And I want to thank you, yes, you, for being there from the start and for staying on up until now. We are taking an appointment for another PATA-REAL by the 19th of June this year. Hopefully you might be a case presenter. So watch out. And when you see our advert for cases, please don't hesitate to send in your cases so that you can share your wealth of experience with others. They can learn from you and you can get better insight as to how to go. So thank you all very much. And we hope that we made this session worth your while. Bye and see you in June.